So I was going to experiment a little in terms of, there's like this new hands up feature, and I was wondering if you'd like to try where anyone who's willing to be picked on can put their hand up, and anyone who isn't, I won't pick on. I don't know whether you want to try that. Wait, let's poll it really quickly. Just something new that I'm trying, because always try new things. Also, can someone mute themselves? Sorry. So while you decide about that, the two main answers that people were thinking about. Oh wait, I'm echoing again. Can everyone just make sure they've muted themselves? Okay, we won't do it, don't worry. The main options that people were going for in this case was a hemolytic crisis or acute pancreatitis. So can someone explain what their thought process was? Anybody in the chat, you can just drop a message in there. What your thought process was with that? Because you're all along the right lines here. Yeah, so both of those very valid. So dapsone is a sulfonamide, which is a class of antibiotics that tends to precipitate these G6PD crises. So it could very well be a hemolytic crisis. Pain radiating to the back is classical of pancreatitis. Absolutely, you should always be considering pancreatitis when you've got like that kind of pain. Vikram's just written Glasgow IMRI criteria. So be more specific. What's made you think of that criteria? For those of you that don't know what that criteria is, we'll get to it in a minute. Don't worry. Yeah, PaO2 is low, which is one of the features of the Glasgow IMRI criteria that you do use to assess pancreatitis severity. So in this case, so this is a tricky SBA because all of these things are causes of like upper epigastric pain. Hemolytic crisis less so than the others. Like hemolytic crisis doesn't tend to present with pain. You tend to get generally feeling unwell, might get some vomiting, but having specific epigastric pain radiating to the back is a bit less common with that. But the other four can all definitely do that. With a myocardial infarction, it would be an inferior one that you'd be worried about in this case. So only one person went for AAA rupture, and I'm surprised. I thought more people might have gone for that because when you see someone with this kind of pain radiating to the back, you should always also think about a AAA rupture. But it is, in fact, in this case, acute pancreatitis. The significance of the dapsone and the G6PD is actually people with G6PD are an increased risk of producing gallstones. Gallstones can get stuck at the end of the pancreatic duct, and they can cause pancreatitis. So that's the relevance of that little bit of the history. So yeah, you need to take into account all aspects of this question in order to get the right answer. This is a really hard SBA. You'll get maybe one or two of these in your entire written paper. So now, what other things could you order? So we already talked about what score you can use to guide your management. But what tests would you want to order with someone with pancreatitis if you're concerned it is pancreatitis? Yeah, so what age do people with G6PD deficiency usually get diagnosed with tends to be like teenage, early adulthood, but like it could actually be any age, but it depends on how severe the deficiency is. One of my friends has G6PD. He's only recently found out. But yeah, you have to realize that it just might not be in his notes because notes are never actually comprehensive. But yeah, that's a very valid point. Serum amylase and lipase, yeah. So amylase, it tends to be massively elevated in pancreatitis. When would you look at lipase specifically? Why is it important to look at lipase as well? So I think lipase has a slightly does actually have a slightly longer half-life. I can't actually remember, but it's the important thing is it's not really specific. You can get amylase going up in other things. So if you're worried about whether it's a pancreatic problem or a non-pancreatic problem, you want to look at the lipase. But yeah, most of the time amylase is sufficient. So if we go on to the Glasgow IMRI score, this is actually a score. I don't know whether you need to memorize it, but having an idea of what's in it is not a terrible idea. And also it's not that hard to remember because it spells out pancreas. The notable thing about this score is, although you use amylase to investigate when you're suspicious of pancreatitis, it does not form part of this risk stratification score. The really important things here to remember and not forget about are the PaO2. Why could PaO2 drop in pancreatitis? Like it did in this patient. Yeah, so pancreatitis is one of the causes of acute respiratory distress syndrome, which you've probably all seen x-rays of recently because COVID causes it as well. But lots of patients get lots of infiltrates in their lungs, and then that's a poor prognosticator, and that indicates severe pancreatitis. Another important thing to note is low calcium. We've been over the causes of high calcium like lots of different times, but there's not actually that many causes of low calcium, but getting pancreatitis can drop your calcium. And this is like really good in like acute pancreatitis. So for those of you that haven't done Mod B, pancreatitis is a condition characterized by inflammation of the pancreas, but it's not like mediated by inflammatory factors most of the time. It tends to be due to autodigestion of the pancreas by the enzymes. So when you block off the pancreatic duct, the enzymes cannot get out into your duodenum, which means they just stay there and they break down your pancreas instead. This is a really, really painful, terrible condition. And there's both acute and chronic variants. And we spoke about how like classical presentation is severe epigastric pain radiating to the back, and they'll probably be vomiting as well. And then I'm not going to go through this massive list again because I've made you do it like 3 times already, but Get Smashed is an acronym that you should definitely know. Here's a few questions for you to answer. So what autoimmune conditions cause pancreatitis? I love how everyone remembers the freaking weird stuff. Yeah, IgG4 and polyarthritis nodosa are the two causes, the two important autoimmune causes of pancreatitis. Like highly unlikely to come up in exams, but question banks ask about it. Anyone know what the scorpion is? I know James knows, but he's not here. Sad. It's the one from Trinidad. Yeah, Trinidad. Yeah, Trinidadi. It's from Trinidad and Tobago. And here is something that comes up. What kinds of drugs cause pancreatitis? Except for steroids, because they're on the list already. There's a few important ones. Yes, so sulfonylureas do cause pancreatitis because of the way they work. They try to increase pancreatic insulin secretion, and putting that stress on beta cells can cause a pancreatitis-esque problem. Yeah, DPP-4 inhibitors, GLP-1 agonists, all of these can, to an extent, cause it. What about non-diabetic drugs? Yeah, notably, mesalazine causes it, but other alazines don't actually cause it that often. But yeah, mesalazine specifically does. Valproate can cause it. Thiazide diuretics can cause it. I think SSRIs can cause it as well. There's lots of things that can cause pancreatitis, but there are some. The important ones are like valproate, thiazides, mesalazine, and the diabetic drugs that cause it. I'm not sure about tetracycline. Let me check for you. While we're talking about that, another important thing is hypercalcemia can cause pancreatitis, but when you get pancreatitis, your calcium will then drop. Like that's a notable thing that happens. So anyone who has like chronic hypercalcemia is at risk of pancreatitis, but then if you test their calcium, it might turn out to be normal or low because of that change. I'm not going to ask you to go through the causes of hypercalcemia again. So what's the sign? So someone's managed to combine both signs, but yeah, this is Gray Turner's sign. And what's that a sign of? What does this sign show? What does it mean that's going on underneath? Yeah, it's retroperitoneal bleeding. That's exactly what it is. And what's the other sign that also represents the same thing? Yeah, Cullen's sign. Miho managed to combine both of them. Impressive. And this is what Cullen's sign looks like as well. So if you ever see these two signs on a patient, either of them, what are the two conditions you have to think about? Ruptured AAA, yeah. And we are talking about pancreatitis, so acute pancreatitis. So if you see these signs, don't forget about those two conditions. How do we manage pancreatitis? Fluids, yes. Supportive management. What else can we do? ERCP. So if we were to put that in an umbrella, we'd treat the underlying cause. And remember that any patient who has acute pancreatitis, which, as I said, is a very serious condition, they need a cholecystectomy down the line because you do not want that happening to them again. So you can't really do very much in terms of acutely, but in the future you want to protect it from happening again. Not protect, prevent. Okay. And don't forget that a lot of people, because of the enzymes, a lot of people's pancreas can go like necrotic, which can cause them to become septic. They'll need like debridement and they'll need like a laparotomy if that does happen. So be wary of that. I've got a few. Do you give antibiotics? If they're septic, give antibiotics. A lot of these patients, so hopefully you've heard of the Q-SOFA criteria for sepsis. So altered mental state, low blood pressure, high respiratory rate. Any patient with pancreatitis is likely to qualify for sepsis under those criteria. So most of these patients will get antibiotics as they come through A&E regardless. Is that okay? So what kind of complications do you get with acute pancreatitis? And how would you split them up? Because I'm just going to split. I like splitting everything up into groups. You could do it into early and late complications. Yeah, definitely. I haven't done it like that, but that is definitely one way you could do it. What else could you do? Does everyone do it early and late? So I find that early and late works better for like chronic pancreatitis more than just a single onset of acute pancreatitis. So I like to do local and systemic. So what kind of local complications can you get from pancreatitis? So what problems can you get with the pancreas themselves acutely? We've already talked about one of them. Bleeding. You can have problems with the enzymes acutely. You can get pseudocysts, you can get abscesses, you can get all of those things. You all know what you're talking about. So you can get all of these problems in and around the pancreas themselves. And then in terms of systemic, we talked about one of them, which was ARDS. And what's the other systemic complication that goes along with ARDS? That you can get with any kind of severely unwell person. I wasn't going for hyponatremia, but they would be hyponatremia because you get like this distributed shock. So they're likely to be hypotensive, etc., etc. So yeah, and don't forget about all of these complications. Right, so I've got some nasty CTs that have come up in question banks before. Does anyone know what this is? This is a pseudocyst, and does anyone know what the difference between a pseudocyst and a cyst is? In terms of cells? Yeah, exactly. So cysts will have an epithelial lining, pseudocysts tend to not. Brilliant. What's this? So this is a very niche diagnosis that I've seen come up in Quez. This is why like I don't particularly recommend Quez, because really weird stuff like this comes up. Does anyone know what this is? So the question you want to ask yourself is, does the pancreas look normal or abnormal? And then if it looks abnormal, what specifically about it? I should have put a normal pancreas to the left of this to make it a bit easier. So this is, it's not really calcified. You might argue there's a bit on the right-hand side or maybe the left-hand side, but that isn't the main thing. Don't worry about this one. This is super niche. Can you see how there's like little strands coming off the right, the left edge of the pancreas? So the patient's left, not my left. Those strands are quite representative of pancreatitis caused by IgG4 disease. And the entire, if you can tell, like the entire like tissue on the outside of the pancreas is kind of swollen. Like it's not all one color, which suggests that it might be inflamed. So this is pancreatitis due to IgG4 disease. Let me put a normal picture of the pancreas for you to compare it to. Normal CT pancreas. There's one in the chat. There's a normal for you to compare it against. Basically, look at the edge of the pancreas. That didn't send. That's not sending either. If you can Google it, that would be quite good. Look at the edge of the pancreas in a normal CT versus in this image, and you'll be able to tell the slight difference. But yeah, this is a question that came up in maybe past middle quiz when I was revising last year. So I just put it in because it might be useful. What's this? You might need to squint your eyes a little. Also, before anyone asks, you don't really need to know anything about IgG4 disease, except for the fact that it can cause pancreatitis. Yeah, so this is a calcified pancreas, and what does this go along with? If you've got this amount of calcification in your pancreas, what are you thinking about? Yeah, this is much more likely to be a chronic picture than like an acute pancreatitis, someone who's been having issues for a while. And with chronic pancreatitis, you get more of the enzyme problems. Sure, you have like really bad pain all the time, but you also have pancreatic insufficiency and diabetes. So you need to give them enzyme replacements, and you treat their diabetes with, I mean, you usually need to treat this with insulin. So what are like some common cause, what's the commonest cause of chronic pancreatitis? How is pancreatic insufficiency different to diabetes? Yeah, good question. So diabetes is where you only have a deficiency in the endocrine function, so you can't produce enough insulin. With pancreatic insufficiency, you lose the exocrine function of the pancreas as well, so you can't produce lipase, you can't produce amylase. You're going to struggle to break down your food. Now that I've told you that, what kind of symptoms might someone with chronic pancreatitis describe other than pain? Yeah, like the big thing is steatorrhea, because you don't have lipase anymore, so it's just going to stay in your bowels, and you're going to get very fatty stools. Yeah. So going back to the question, commonest cause of chronic pancreatitis? Alcohol is the commonest cause by far, I think. And then there's a couple of genetic causes of chronic pancreatitis. Do you know what those are? I think you do need to know. You need to know them. Yeah, cystic fibrosis, because you have problems with the exocrine secretions because of the thick chloride problems with the chloride transporter. Yeah. There's one other one that you learn in gastro. They might not have told you that it causes pancreatitis, but it can. So hemochromatosis can cause pancreatitis alongside bronze diabetes. It can cause a general pancreatic insufficiency and can cause inflammation of the pancreas. So both of those are hereditary causes. But yeah, I think for your exams, acute pancreatitis is probably more likely to come up than chronic. Can Wilson's too? So copper doesn't tend to deposit in the pancreas, so usually not. So if we take a quick detour to talk about Wilson's disease, it's a problem with chelating copper, so you get lots of deposition around your body. So like, where are the common locations that copper deposits in your body when someone has Wilson's disease? Eyes, and what sign is that? Basal ganglia, especially within the brain, yeah? You can't spell it, yeah. Kaiser-Fleischer rings, if you look at them under a slit lamp, they can get Parkinsonism in the basal ganglia. They can get psychiatric symptoms as well. So lots of different things. Presents very non-specifically. Okay, that's everything I was going to talk about in terms of pancreatitis. If there's any questions, let me know. So let's talk about another case. So once you've had a read, what is the most likely diagnosis? Yeah, so this is quite likely to be aortic stenosis. And why do you think this is likely to be aortic stenosis? What things in the history put alarm bells on aortic stenosis? A murmur radiating to the carotids, a systolic murmur to be specific, yeah, is very highly likely to be aortic stenosis. What about the symptoms? Age, yes. So aortic stenosis is very common as you get older due to degenerative calcification. Right-sided symptoms of heart failure. So it's, I mean, shortness of breath on exertion is more likely to be left-sided heart failure because it's going into the pulmonary vessels, the backlog of fluid. So you're getting fluid in your chest. Yeah, absolutely. So shortness of breath on exertion, and these are signs of left-sided heart failure. Yeah, very important. And the reason I gave you this case was so we could talk a little bit about heart sounds. So what are the two normal heart sounds in all people? S1 and S2, absolutely. And then S2 is the dub, but I forgot to put it on. And then you can have S3 and S4, which are some S3 can be normal. S4 is almost never normal. What does S1 represent? Yeah, S3 is in healthy young people. Yeah, so closing of like the valves in the middle of your heart, so the mitral and tricuspid valves, and it shows when systole is starting really. And therefore S2 would be, now that you know what S1 is, you can guess this one if you didn't know. Aortic and pulmonary valves closing, absolutely. So any kind of valve pathology, you're going to get weird sounds going around these heart sounds. What does S3 represent? So like, I don't think you're ever taught what the extra heart sounds actually represent. So I think it's actually quite useful to know, because you can kind of figure out what's going on if you understand it. So S3 could be a ventricular gallop, but that's like a specific cause of an S3. Blood rushing against the ventricle. So that is basically what it is. It's basically the sound of diastolic filling. In young people who have quite dynamic circulations, you can hear it. It's not actually like, it might be due to overcompliant ventricles. It tends to just happen in young people and anyone with problems filling during diastole. So what kind of things can cause an S3 heart sound? So anyone have any ideas? Yeah, so hyperdynamic states can definitely cause it. Yeah, what else? When else might you hear a problems? Yeah, systolic dysfunction can cause it, but you actually get a lot of a problem in diastolic dysfunction as well. I think the main thing here is S3 is not actually a specific sign at all on examination. Like if you see an S3, if you hear an S3, if you can see one, that's impressive. You probably need to echo them to find out what's going on underneath, unless it's a young person. Any idea what S4 does? S4 is always pathological. S4 is a much more important sign than S3. Yeah, so atrial gallop, blood hitting against a non-compliant ventricle. These are all causes of an S4, but yeah, the big thing is S4 is often the atria contracting against a stiff ventricle. So that's like what the sound is in terms of S4. So when would you have, what kind of things cause a non-compliant ventricle? Think long-term cardiac conditions. Yeah, so you can get like a restrictive or an obstructive cardiomyopathy if it's going that far down. Yeah, but more common in restrictive. You can get it in stenosis. You can get it in Hockham. Yeah, you can get it in a lot of different things. But yeah, if you've got a stiff ventricle that isn't really compliant, you might get an S4. Again, it's not specific for a certain condition, but these are the kinds of conditions you should be thinking about. In reality, the main heart sounds they'll ask you about in your exams are S1 and S2, but what they do love asking about are valve disease and murmurs. So, like, I know you don't have an OSCE, but a cardio exam in an OSCE is always, like, it's almost always an aortic stenosis murmur. Restrictive cardiomyopathy caused by infiltrative conditions. I can't remember off the top of my head, but you probably can't. They can cause it. Infiltrative conditions can cause everything, so probably. Is there a difference between gallop sounds and S3, S4? So I never really paid attention to the gallop sounds, and I just learned them as S3 and S4. So I can't actually remember off the top of my head. I think gallop sounds is like they're like specific causes of like S3 and S4 that happen straight after like S2. I think S3 is the same as a ventricular gallop though. I've never actually heard S4 be referred to as an atrial gallop, but that's really interesting to know actually. If you're going to learn one of these valve diseases, learn aortic stenosis. It's the most common and probably the most likely to come up. Fine. So I'm not going to play sounds, but like you can tell me the murmur. What is this murmur? I mean, it could be aortic stenosis, but what's the murmur called? Yeah, so this is an ejection systolic murmur. And remember that there are multiple causes of an ejection systolic murmur, the commonest of which is aortic stenosis. So absolutely correct. So remember that you can either get aortic stenosis or you can get aortic sclerosis. And what's like the difference between those on examination? No radiation to the carotids is what like they tell you. I'm unconvinced, but that's what you would put in your exams. And what kind of symptoms do these guys get? Syncope, yeah. What else? Oh, Mark knows the triad. Yeah, chest pain or angina, shortness of breath, and syncope is the important triad. Yeah, always keep in mind this triad. And what kind of causes can you think of for aortic stenosis? What do you think the commonest causes in the UK? Degenerative calcification is the commonest cause. What if they're a young person, they're like 40 years old? Bicuspid aortic valve, definitely. And post-traumatic fever scarring is a cause of every single valve problem. So it's not very common nowadays, but it's always something to keep in mind, especially if they've migrated to this country from somewhere where rheumatic fever is still a problem. What is the most important differential for aortic stenosis if someone has syncope during exercise and they're young? Hockham, absolutely. If someone just randomly like collapses during exercise, you need to always think about Hockham if they're young, and Hockham also because you get narrowing at the top, just below the aortic outlet. They can also get an ejection systolic murmur, so always keep in mind Hockham. We can talk about Hockham another day or at the end if we have time, but I won't go into it now. Management of aortic stenosis. What does it depend on? The general principle. Yeah, absolutely. Do they have symptoms or do they not have symptoms? What do you do if they don't have symptoms? There's two things you do if they don't have symptoms. So conservative management, you watch and wait, and you do one other thing there. Yeah, you echo them. You check if the gradient, the pressure gradient across the valve is above 40. If it is above 40 and they have left ventricular dysfunction, you're going to want to do a valve replacement. If they're symptomatic, you're going to want to do a valve replacement. So what's like the gold standard when we replace valves? If you you had a 50-50 chance, and unfortunately that is not the correct 50%. But yeah, you would think that TAVIs would be like the gold standard, but they're surprisingly not. So if they're healthy enough to survive like general anesthetic and a major operation, you actually want to do an open valve replacement. I think that's changing nowadays, but last time I checked, these were still the guidelines. And before you do an open valve replacement, you also do an angiogram, because if you see that they've got lots of clogged vessels while you're in the chest cavity, you might as well fix some of those as well. But yeah, if they're not suitable for surgery, then you do like a balloon valvuloplasty and replace it using a TAVI. But yeah, I think so. In a few years, it might change, but I think we still get better outcomes with open heart valve replacement than we do with TAVIs. And remember, when you eventually have an OSCE, if you see a patient who has a midline sternotomy scar but doesn't have venous grafting scars on their legs, you should always think about a valve replacement. And people with older valves, you can often hear their valves from the end of the bed if you listen carefully. So that's a good trick for OSCEs. But yeah, main thing, replace the valve. Spoilers, answers to most of valve disease is just replace the valve. Other features of aortic stenosis. So let's, what pulse features do you get with AS? I put pulse in quotation marks because one of them's technically not to do with the pulse itself. Yeah, so when you examine the patient, if you're like godlike with pulses, you might notice a slow rising pulse. I couldn't tell you when a pulse is slow rising. I'm sure some of you can. And then the other thing is to do with their blood pressure more than their pulse. You know what you get? Narrow pulse pressure, yeah. So can someone tell me what pulse pressure means? Difference between systolic and diastolic. Yeah, that is exactly what it is. If asymptomatic, how would you pick up aortic stenosis? Left axis deviation on ECG, isn't it diagnosis on echo? So diagnosis is on echo, but you should be able to pick up a murmur on examination unless it's really quiet. Remember that most of these patients will be symptomatic because they'll present with syncope or something. But yeah, a narrow pulse pressure means that the gap between the systolic and diastolics is small. It might be something like 10 or something. I don't know what the actual cutoff is. And then ECG findings, someone mentioned one of them already, so which was left axis deviation, but what's the other ECG finding? Also, Ahmed is still planning to do an ECG session at some point. Left ventricular hypertrophy. Yes, absolutely. So your lateral leads are likely to have big QRS complexes. So always remember your ECG signs. Fine. Next, murmur. So what type of murmur is this? Yeah, this is pansystolic. And the most important cause of a pansystolic murmur that you need to know is mitral regurgitation. Absolutely. So causes of mitral regurgitation? Don't say rheumatic fever. We know that that's the answer to everything. So You can get AF with mitral regurgitation. AF causing mitral regurgitation is less common. Endocarditis, definitely secondary to myocardial infarction if you get rupture of the papillary muscles. Connective tissue diseases like Marfan's and Ehlers-Danlos. Yes, all of these are correct. And you're absolutely correct. Kakashi arthritis. I don't actually know what that is. I'm very interested to know. I don't know what that is actually. Kakashi's arthritis. That's really interesting. Sorry, I'm going to Google it. We can come back to it later. With mitral regurgitation, it's more. They don't really ask you about management, but generally replace the valve. If they're in heart failure, manage it medically. So what part of the heart is likely to suffer due to mitral regurgitation? Which of the quadrants of the heart is likely to suffer? Yeah, it's left atrium, because as it doesn't close, you might have the high pressure in the ventricles pushing against the left atrium. So how do you know if the left atria is enlarging on an ECG? What are you going to look for? Which bit of the ECG? So yeah, you want to look whether it's irregular, because you might get AF. Yeah, and you can get like weird P wave signs. You can get big P waves, or you can get bifid P waves as the atria enlarge. So yeah, have a look at the P waves. Right, next murmur. What murmur is this? Sorry, this one isn't super clear, but I mean, you should get it still. Yeah, this is early diastolic. And what is a cause of an early diastolic murmur? That is becoming more and more uncommon. Aortic regurg. Yeah. Could be a grain steel murmur. But yeah, no, there's one other important cause of this murmur. Mitral stenosis tends to be a mid-diastolic murmur. Any ideas what the other cause is? So I'll give you a clue. I mean, yeah, so yeah, always remember, like every single right-sided murmur has a left-sided murmur. Left-sided murmur will also have a right-sided murmur that goes along with it. Okay, so yeah, so the most important in this case is, okay, the presentation's gone. Let me get it back. Give me a second. Don't forget about your right-sided murmurs. They're a lot quieter, but they're still important to know of for SVAs. So aortic regurgitation, what is the most important cause of aortic regurgitation, or what are some of the causes of aortic regurgitation? Ankylosing spondylitis. I mean, yes, but is that the most important cause? Probably not, but yeah, sure. Ankylosing spondylitis. Any regurgitation murmurs, you should be thinking of connective tissue diseases like Marfan's or Ehlers-Danlos, or where to go. What else? Aortic dissection. Yeah, absolutely very important. Syphilitic aortitis. Yes, very important. I'm on gum at the moment, so I've had teaching on that. That's very interesting. What else? Is there a good way of splitting these up? Congenital causes. I guess you could get like a congenital cause of that as well. Aortic root dilatation. Yeah. Let me just find my slides. I have a good way of splitting this up. So I like to split them into problems with aortic. Yeah, I mean, Mark knows it, but yeah, split it into problems with the valve, split it into problems with the root. Anything that causes aortic root disease can cause aortic regurgitation and problems with the valve. So dissection, connective tissue diseases, tertiary syphilis. What antibiotic predisposes you to dissection and can also cause this? Does anyone know? The clue is it's the same antibiotic that messes with the connective tissue in your Achilles tendon. So not macrolides. Yeah, Cipro. So anyone on Cipro is actually at increased risk of aortic dissection. And I think the literature is now reflecting that. There's been lots of cases of people getting dissection due to Cipro. And then you have your intrinsic valve pathologies that are kind of the same for all of the valve diseases. The only thing I'll ask you about more is, so bicuspid aortic valve is congenital. What's a Liebman-Sachs endocarditis? I mentioned this in the room lecture. It's kind of rogue. Yeah, it's lupus causing endocarditis because you get immune complexes attacking the valves. So it's a non-infective endocarditis, but you can get all of the peripheral signs of normal endocarditis. Right, another one, last one. What's this murmur called? Mid-diastolic murmur, yeah, it's caused by mitral stenosis. And there's a joke, there's like a really old joke in medicine. So what are the 3 commonest causes of mitral stenosis? Rheumatic fever. Ah, I love people who know this joke. Yeah, so the 3 commonest causes of mitral stenosis are rheumatic fever, and rheumatic fever. But nowadays you get all of the other weird causes of mitral stenosis. But if you're going to remember one thing about rheumatic fever, it causes mitral stenosis. Vikram has clearly had too much teaching by me. And you get a mid-diastolic murmur with an opening snap, and I'm an idiot because I wrote early diastolic. What happens is you get it as it becomes more severe. Guess you had to be there. It was early in the year. It was in a MedSoc session, I think. Yeah, so the murmur itself gets longer. One other thing happens. What happens to the opening snap as mitral stenosis gets worse? Yeah, so it snaps closer to S2. So the snap itself actually happens a bit earlier as it becomes more severe. And then you can get other signs with mitral stenosis. You can get the malar flush, and you can get AF is actually a lot more common with mitral stenosis than with any of the other murmurs. But of course, AF is like one of the commonest conditions in medicine. So a lot of these patients will have concurrent AF anyway. And then we spoke a bit about the ECG signs for mitral regurgitation. But what's the important, again, what were they? So you get enlargement of the left atria. So what are those signs, the 2 signs? We'll see who was listening. Left axis deviation, maybe not really left axis deviation. Remember that the axis deviation happens more with ventricular hypertrophy. But yeah, it was the bifid P waves or the tall P waves, depending on which thing thing you're looking at. What is the sign for bifid P waves called? What do they call it? What do cardiologists call it? P mitrale. Yeah, exactly. You should always look for anyone with mitral stenosis, not in an exam, but in real life. If someone tells you someone has mitral stenosis, see if they have P mitrale and they have the bifid P waves, just for your own education. Right, we're going to play a game of guess the sign. It tells you the names of these signs. So aortic regurgitation is a really strange thing that causes loads and loads and loads of different signs. So what's the sign in the top right? Water hammer pulse. Yeah, I couldn't actually find like a diagram of it, so I just put a water and some hammer. No, hammer and some water. And where are you going to assess the water hammer pulse during your cardiovascular examination? Yeah, so the best pulse to use for the water hammer pulse is the radial pulse. And remember to put your fingers need to go across your radial pulse, because you should be able to feel it go downwards. So you need to use multiple fingers. Use 2 or 3 fingers when feeling the radial pulse, and you can feel it drop down each of the fingers. I'm just aware that some of you haven't had a cardio placement, so this is the kind of niche knowledge they teach you. Why is there a gun on the slide? Taub sign, yes, Traub sign, pistol shot femorals, absolutely. And then before I play the video, what is Corrigan sign? It is not head nodding, but we'll get to that in a minute. You get fluttering carotids and massive carotid pulsation. I'll show you the video. Is this video playing? Is that playing? Ah, rip. You can watch these in your own time. But yeah, with this, you basically have massive pulsatile femorals. That's a shame. Wait, let me share my screen. Hopefully you'll be able to see these. These are kind of cool. PowerPoint. So yeah, aortic regurgitation is effectively characterized by loads of these signs that happen in tandem with your pulse, which is very interesting. So you get lots of peripheral signs with it. Right, let's do this. Damn it, I can see myself. Share screen. Right, can you see my screen? So what part of the body are we looking at? So this is Muller's sign. Does anyone know what part of the body this is? It'd be really funny if the video is not playing again. Yeah, we are looking at the uvula. That is exactly correct. So you get the uvula pulsing up and down in tandem with your pulse. This is the head bobbing sign that someone mentioned earlier, Demasit sign. It's very subtle. I'm not sure if you can tell. I also hope the weird music isn't playing in the background. Okay, and then the other one that you might see is Quincke's sign. So you can see pulsation in the nail beds. I'm not sure if you can see that, but if you look carefully, it gets darker and lighter in tandem with the pulse. And one for your interest that will never come up in your exams is Landolfi's sign, which is dilation of the pupil in relation to the, I'll play it again, in relation to the pulse. But yeah, so like the different signs for aortic regurgitation do actually come up in exams. Very unlikely to come up in an OSCE, but in terms of exams, they can ask you about them. And it is important to actually try and examine for these. Right. So last case for today. What do you think is going on? Woo, Dartmoor, Southwest England for the win. I guess that made one person unrealistically happy. So someone said Lyme disease. It could be. So what is making you think about Lyme disease? Climbing trip, maybe someday. The fact that she's called Miss Lemon. Yeah, sorry, I'm bad at making up funny case names. Yeah, but the important thing is you get like south of England, all of these national parks have lots of ticks around, and Lyme disease is carried by ticks. But there are other things to consider if she hadn't gone to Dartmoor. So say she hadn't gone to Dartmoor, what else could this be? By the way, this is Lyme disease, but just for the sake of conversation. Yeah, it could just be any kind of viral flu that can cause lots and lots of random symptoms around the body. What could be causing the chest pain? I mean, they could have like a costochondritis. They could be having heart block, but heart block doesn't tend to be painful unless they're getting ischemia due to it. What else could it be? So in Lyme disease, there's a very specific thing that causes chest pain. It's not very common, though. Does anyone know what it is? Yeah, it's myocarditis. So it'll be pain that's better as they sit up in bed rather than when they're lying down. And remember that with myocarditis, pericarditis, there's like an overlap between them, and some causes of the flu can also cause myocarditis or pericarditis. So what virus commonly causes pericarditis? That we talked about on Monday, I guess. Yeah, Coxsackie virus, exactly. And like Coxsackie virus is probably a lot more common than Lyme disease. So you should still be thinking about things like that. But yeah, this is Lyme disease. And what is this rash called? This is the classic rash that you get with Lyme disease acutely. Erythema chronicum migrans or erythema migrans is enough for your exams probably. And it's this, you get like one bullseye rash at the point at which you've been bitten by a tick. Target rash, yeah. And so someone once asked me, like, what's the difference between this target rash and erythema multiforme? And the only real difference is the fact that there's only one of these. Erythema multiforme tends to cover your entire body, or at least part of your limbs with it. So if there's only one of them, you should think of Lyme disease. So Lyme disease, fairly interesting condition. What are the classical features of Lyme disease? We've spoken about a few of them. Yeah, so you have 3 phases, and I'm not going to lie, like, if you're interested, you should definitely learn about the 3 phases, but in your exams, they're probably not going to ask about it. a bit shorter. So you have the rash. What else do you have? You can get facial nerve palsy. Yeah, definitely. Around 10 to 15% of cases get a facial nerve palsy. What else? Joint pains, fatigue, cardio signs. Yeah, so you can split them up. You can get dermatological sign, which is the bullseye or target rash. You can get cardiological manifestations such as heart block or myocarditis, or you can get neurological manifestations like a lower seventh that we discussed on Monday, or meningitis. And how do you diagnose Lyme disease? What's the causative organism before that, actually? So not microscopy, actually. It is ELISA. ELISA is, so you're going to check for antibodies against it. Absolutely. So yeah, Sarah hit the point on the head. If they have a bullseye rash and you think it's Lyme disease, just treat for Lyme disease. If they don't have a bullseye rash and you've got that history, you can either do an ELISA for the antibodies, you can do an immunoblot, and both of these tests can come back negative. And if they come back negative and you're still suspicious, you can repeat it later and start empirical treatment. So keep that in mind. But yeah, if they have a rash, if they have that rash, just treat them immediately. And how do you manage it? Doxycycline, absolutely. I wouldn't learn about amox or ceftriaxone. I don't think they'll ask you about it. But yeah, if it's early Lyme disease, i.e. they don't have all of the organ systems involved, then you can just give them some doxycycline. And the last thing I wanted to talk about is, when do we use doxycycline? So it's kind of the tetracyclines are a kind of a weird group of antibiotics in that they work on lots of different things, and they also don't work on a lot of different things, despite being quite broad spectrum. The way I remember it is they're really useful for lots of weird tropical diseases, and you can use them for some normal infections if people are pen allergic. So normal infections you might use it for if someone is pen allergic include things like ear infections, chest infections, but like I wouldn't worry too much about that. What they'll probably test you on is anything weird and not from this country. Most of the time you can treat with doxycycline. It's really good against tropical diseases. So if they give you a tropical disease, which, as I said, is pretty unlikely to begin with, and you don't know what the answer is, putting doxycycline isn't like a terrible shout. What will come up much more than that is the side effects of doxycycline. Any ideas? So photosensitivity, or sunburn prone is one of them. So not quite yellow or black teeth, but you tend to get translucent teeth. There is something, not black teeth, but black something else is an important side effect. Could be black tongue, not that common. So black liver. Are we just going to guess all of the organs now? That's funny. Black hairy tongue is like the classical side effect of using any of the tetracyclines. You get the tetracycline teeth, and you just avoid them in pregnancy because they can cause tetracycline teeth and they can prevent bones from developing properly. But yeah, those are like the really like the main takeaway from this slide is the side effects. They might just show you a picture of a black hairy tongue and be like, what is this? That could happen. So know the side effects. Generally with antibiotics, I've said this before, the side effect profiles of the antibiotics is almost more important than the spectrum of action. Although, as I said, know the empirical treatment for common infections, like pneumonias, ear infections, endocarditis. I think that's all I was planning to cover today. Does anyone have questions about anything we've done? Some people have messaged me on Facebook. Is the bullseye rash where they got bitten or just random? So it is where they got bitten. Oh, thanks. That's useful to know. So TAVI data. So TAVI versus open surgery. It's because we have very little evidence for TAVI on people who have lived over 20 years. So we don't have data rather than there being bad data. Sorry. Any other questions? Let me stop the recording there as well. I'm just going to send you a feedback form as usual. What module does Lyme disease fall under? Neuro or ID? Probably neuro more than ID. Like, I don't really learn things by module, which is because I feel like everything just overlaps. Anyway, fine. Which murmur is it that gets quieter with severity? Aortic stenosis. So I think it does because there's less blood rushing past it as it's worse. Like blood struggles to travel as high a velocity as the stenosis is worsened, so it does tend to get quieter. Any other questions? I think Ahmed's planning to do some cases on Monday. Sorry, I'm losing my voice today. So I'm just dying, really. And I ran out of tea again. It's very sad. I think you try TAVI. If you can't use TAVI, you can do a balloon valvuloplasty. Okay, cool. Thanks, that's really useful. What does the bottom bit say? Oh, sorry. Yeah, it was just the thing was covering over it. So doxycycline you want to avoid in pregnancy because it can cause problems with bone development and teeth development in the fetus. Takayasu's aortitis was for aortic regurgitation. Yes, it is inflammation of the aorta due to autoimmune conditions or due to syphilis can cause it. Yeah. Any other questions? Yeah. If anyone wants me to go over anything specifically, I can actually stick around for 15 today. So yeah, message me if you do. I obviously don't have slides though. Will you still do teaching after COVID? So that's actually interesting. I've been talking to Vikram and the MedSoc person taking over next year, and we're going to try, if teaching on campus resumes next year, we're going to try and do this in real life opposed to online because it works a bit better. What would you see in a late diastolic murmur? I don't know. What would you see in a late diastolic murmur? Is this a riddle? Late diastolic murmur. Atrial myxoma can cause it, apparently. What difference is between mid-diastolic and late diastolic? To be fair, I don't think you need to know late diastolic, if I was to be honest with you.